Well, hey folks, my name's Kevin. I'm a paramedic practice educator on Vancouver Island, and thought I'd put out another little video just on some stuff of common interest to paramedics and for medicine in general. So yeah, I hope you find it interesting. We'll go through a few things, and if I get too long-winded and boring, just turn me off. Nobody blames you, it's fine. So today I thought it might be kind of interesting to get into the topic of anticoagulation. It's something that we deal with a lot in our patients. Many of the patients we see will be anticoagulated to some degree, but there's different aspects to this, and I thought it might be nice to kind of break them down so that you can recognize people who are anticoagulated, maybe which kind of anticoagulation they're on, and what it might mean in that patient presentation, especially if we're not getting a great history, perhaps from the patient or from the family. So yeah, I think it's going to be super awesome. So strap in and we're going to dive into some anticoagulation. Should be a lot of fun. So to start off, the term anticoagulation is a bit broad. When we talk about anticoagulation, what we're talking about is a group of drugs that are going to stop blood clots from forming. We're not really talking about breaking down the blood clots. That's something very specific to thrombolytics or fibrinolytics, things that are given perhaps in the case of stroke or in areas where there isn't a cath lab for myocardial infarction, for MI, when they give drugs like tenecteplase or TNK, like some of the ACP crews do around the province now. So anticoagulation is a bit of a broad term. And what I wanted to do is just kind of break it down into sort of the two parts. What we really have is we kind of have two things to talk about. The first of those things, the first part of anticoagulation, are actually antiplatelets and antiplatelet therapy. And I want to take a second to distinguish that from actual anticoagulation as it's talked about in the traditional sense. So why don't we start by talking a little bit about antiplatelets and how they work and what's going on. So you can see here that I have a bit of a diagram of a blood vessel. All right, so this is just a regular old blood vessel. Nothing exciting about it. It's probably not really what it looks like, but it's good enough for my artistic capabilities. And what we see here is we see a couple of things. First of all, the black is just the basement membrane or the membrane around the vessel itself. The blue is just endothelial cells within the blood vessel. Then inside the blood vessel, of course, we have blood. So here's some red blood cells, and here's some platelets, these funny little dudes with the little arms. So what I want to talk about is just kind of what we're dealing with in terms of when these are used. When does this normally, when do the platelets jump into action, and how does clotting actually work? And then we'll get to what people are on and what difference it makes. So first of all, to talk about how clots form in general, we'll say that we have an injury right here. Okay, so they have a blood vessel and they get themselves a boo-boo right here, okay? So they get themselves a boo-boo, and blood is going to start pouring out, which is, not optimal. So we start to get, blood leaking out. They start to bleed. Well, what happens when this blood vessel is disrupted from whatever means is that a lot of this basement membrane is exposed. As well, some normal chemicals or chemical mediators, you might call them, that these cells secrete are all of a sudden stop being secreted in that area. And these cells normally secrete a few things that keep these platelets happy, right? So in normal physiology, there's some drugs that come out, there's some chemicals that come out of the endothelial cells that kind of interact with platelets. And what these do is these keep the platelets very, very happy, right? So these happy platelets, they don't clot. They're not going to clot, they just bounce around in the bloodstream like normal. When we disrupt the tissue, a couple of things happen. This basement membrane is exposed, and we're in an area where now there's not this intact endothelium to put out these mediators that are keeping the platelets happy. As a result, one of the first steps in the whole clotting process is that platelets become activated and start to form a platelet plug, as it's called. So when this occurs, what we see is that due to this injury with all this bleeding, first thing that happens is these platelets become activated and start to plug up the hole here. Wait, can't forget the little arms because it makes it look cool. Anyways, you get the idea. So we get a platelet plug that forms as the first step towards stopping the bleeding that's going on. And as this platelet plug starts to form, what happens is the first platelets that attach there actually become activated by different chemical mediators, like I said, on the basement membrane and whatnot. And they start to spill out other chemical mediators. And some of the chemical mediators, we don't really need to get into too many of the names of it, but there's a lot of different things that go on in the platelet that start to cause more and more platelets to clump together. So one of the things that causes more and more platelets to clump together that these platelets that are now activated start to make is they start to make something called thromboxane, which is sort of abbreviated TXA2. Now, it's an unfortunate acronym or abbreviation because it just doesn't really have anything to do with the TXA that we give. It's just this is the shorthand for thromboxane A2. In fact, you know what? I'm just going to call it thromboxane A2. And that's produced by the platelets. So the platelets start to pump that stuff out. So here's our platelet. It's funny little arms. And this platelet, when it gets activated, it starts to put out thromboxane A2. In addition, it also puts out something called ADP. Why is this relevant? You might say this sounds super boring. I agree with you, it does sound boring, but it's relevant in that when thromboxane A2 is produced, what it does is it brings other platelets in and makes them stick together. Okay, so what it does is it creates more calcium inside the platelet and it starts to send out a bunch of other mediators and start to cause a lot of clumping of these platelets to form the platelet plug, which when we're hurt, sounds like a great idea. That's what we want. So the thromboxane A2 is relevant because we give medications that actually stop the production of thromboxane A2. At the same time, these platelets start to put out what's called ADP. And yeah, that looks like crap, huh? I can probably do a better job of actually writing that up. These things start to put out ADP. And ADP kind of does the same thing as thromboxane A2. It talks to other platelets and it tells them to start clumping together a little bit more. And the ADP actually uses another binding site on the platelets itself, which is relevant as well for another drug that's given when somebody has an MI or something, somebody that you might see post-MI might be on this drug as well. And we'll talk about those in a second. So just to recap, somebody gets a boo-boo in normal physiology, a platelet plug starts to form, these platelets start to clump together, and then as time goes on, you start to see things like fibrin, which is like a mesh that comes together and starts to actually stabilize this clot a little more, and some red blood cells are trapped in there, the platelets, a few other things as well. But for all intents and purposes, what we're concerned about at this point when we talk about antiplatelets is what medications can we give to keep this platelet plug from forming. We're going to talk a bit more about that. Over here, you can see where I've just drew obviously I'm speaking very well. I've just drawn another example of a blood vessel, but in this one I've put what's called an atherosclerotic plaque in here, and this is what we're concerned about in people who have MIs, who have a buildup of a plaque in their coronary arteries or in an artery in their head perhaps, and you can build up this plaque over time as lipids and a bunch of other crap ends up inside this plaque. And what can happen, as we know, is that this plaque, with all the forces in the artery and everything like that, can become disrupted pretty easily. And if this becomes disrupted, what happens is all of this side, inside, is exposed to the blood. And these platelets, they love that stuff. They go like sweet and they glom on there. And all of a sudden, what you end up seeing is you see these platelets, when exposed to a little bit of this plaque, all of a sudden, boom, they're in there. They're doing their thing. They're sending out these different mediators, thromboxane A2 and ADP and a bunch of other stuff, and they start to get in there and form this nice big clot because that's their job and they're just doing what they're told. Now the problem with that is that if this is a main coronary artery and this quickly happens, well, obviously we have a problem because there's the chance that we can clot up and block this entire vessel and prevent all this downstream blood flow. Next thing you know, you're having a stroke or you're having a heart attack. So, and that's pretty unfortunate. So this takes us back to the antiplatelets and the therapy that we're on. So we talked about a couple of things and I'm just going to highlight it now. I'm going to use a different color just for funsies. So a couple of antiplatelets that you'll hear about and that we use. The first one, I don't think it's going to be any surprise to anybody, is aspirin, or ASA. And ASA is used as an antiplatelet because ASA specifically blocks the production of thromboxane A2. So it stops the ability of thromboxane A2 to go and tell other platelets that, hey, there's some stuff going on, let's do something. So that is one of the reasons why it's one of the first things we do. If somebody's plaque ruptures, say they're having an MI, they're having chest pain, we think that they might be having a myocardial infarction, a STEMI or an OMI or whatever we want to call it, is that we want to stop this plug from getting worse, from forming, from becoming bigger and bigger, so that our body's natural process has a chance to break down that clot a little bit and minimize the damage or the time that we're affected by that MI. So one of the first things we want to do is give ASA. Now we can talk quickly about how much ASA. We give 162, right? We give 2 small 81 milligram tablets. That's fine. I think dispatch sometimes will tell people to take 4, give 325. I think the reason for that is because a lot of people might have a regular aspirin lying around the house, which is 325. And if they don't have the baby aspirin, we don't want to not give people aspirin pre-hospitally for the time it takes for a crew to arrive. So it's better to have them choose something than nothing. But what we really need to give is just 82 times 81 milligrams. So the 162 is, it does the job and it inactivates those platelets and blocks this process. What you'll see then is when you get to the hospital side of it, or if ACPs are giving TNK, or you go to the hospital and they're getting PCI, or they're going to get thrombolized there, is you're going to see they'll also give something that'll block the ADP from doing kind of the same thing as thromboxane A2. So they're going to give something called clopidogrel. Or you might see them give something called ticagrelor. So these two things here work on basically where the ADP is binding to other platelets. So it's actually called a P2Y12 inhibitor if you really want to nerd out about it. And that's the site where this binds on other platelets. So these things are the antiplatelets that go into somebody. ASA, big bang for the buck, let's give it. Clopidogrel and ticagrelor, those are given in the setting of somebody having an MI or maybe an NSTEMI. And what's interesting is that these are also given for a period of time after somebody has had an MI or possibly a stroke as well. So these will be given for maybe a few weeks or a month in somebody who's had a stroke. They'll be discharged from the hospital taking both ASA and probably clopidogrel. If you've had a stroke, if you've had an MI, you might end up taking 2 of these as well, but you can take it for longer, like up to a year or even more, to make sure that that person who has had some work done in their coronary artery still has some crappy plaque lying around, to make sure that that doesn't clot up again. So they'll end up on what's called dual antiplatelet therapy. And then after a while, that'll be tapered off. And just to speak to that quickly, the reason we taper that off or take it away is because anytime you're giving any anticoagulation in the broad term, antiplatelets, or we'll talk about anticoagulants in a sec, is that giving these keeps these bad clots from forming, but it also increases your bleeding risk. If you're just going about your daily life and you're on both of these things and you're feeling fine, and then you fall over and smack your noggin, well, now you've got an increased risk of bleeding in your brain, or just bleeding from your skin, or whatever the case might be. So it's all a risk versus benefit balance in terms of who ends up on antiplatelets and anticoagulation. And that's always kind of the give and take, and why I'm sure everybody here has had the question, are they anticoagulated in the setting of a trauma, especially? Like, are you going to have trouble bleeding? Because they need to find ways to deal with that if the person is anticoagulated but now has some additional trauma. So there we go. Antiplatelets, we have aspirin, clopidogrel, and ticagrelor, and that's sort of keeping this platelet plug from forming, or keeping this platelet nastiness from forming in the setting of somebody who has an atherosclerotic plaque and is causing the MI or maybe a stroke. So that's the first side of this that I want to talk about. Just one quick note. If you are on the clopidogrel or the ticagrelor, if you find somebody, like I said, maybe a poor historian or the family doesn't know, and you notice that they're on ASA and clopidogrel, which is also called Plavix, and we'll get to that in a second as well. I'll show you a little chart around trade names and brand names. If they're on both of these things, that kind of gives you a hint that whatever happened in the past, whether it's a stroke or if it was an MI, you're only a certain distance from when that happened. Usually the dual antiplatelet therapy in an MI is around a year. So if you see somebody on both, you know that they have a more recent cardiac history from either a STEMI, maybe they had a cardiac catheterization, or they had TNK or whatever, but they ended up getting discharged with both of these. With a stroke, like I said, if you see somebody who had a history of a stroke and they're on both of these, that might be a pretty fresh stroke, only a few weeks old. So that's just something that can help you, knowing that you don't normally have both of these for a long time. So that's a lot of talking. Let's switch gears and go over and talk a bit about anticoagulation. What distinguishes these two things? Why are some people on different anticoagulants and why are some people on antiplatelets? Well, this process here that we talked about with the plaque rupture and the little platelet dudes all clumping together, this tends to be what happens a lot in the arterial system. So in the arterial side, so think of a coronary artery or think of a cerebral artery in the brain where you have a plaque or you have something that's causing a little bit of endothelial damage inside, this tends to form very platelet-rich clots. So in that setting, having antiplatelets is really good for that arterial side of things. So people who have had an MI, people with a stroke, you want them on an antiplatelet to prevent this from happening, because that platelet plug, you don't want that thing to form, because it doesn't matter if it's only there for a few minutes. A few minutes of blocking a coronary artery or a cerebral artery, no bueno. So we don't want that to happen. When we talk about anticoagulants, these are attacking what's called fibrin. Remember I mentioned fibrin is kind of the mesh that holds everything together? Well, what we see is if a clot is there for a while and it starts to build up in your sort of, we'll call this the generic vessel, what happens is this fibrin now starts to come in and form this mesh around everything and trap some red blood cells and more platelets and everything, and it makes a stronger clot. So it increases the clot's strength so that it's going to stay there and not disappear. So we really want that fibrin to stay. Actually, that's why we're giving TXA in trauma too, is we're trying to make sure that this fibrin stays where it is and doesn't get broken down. So this fibrin mesh that's going on here, the clots that form when we don't want them to, in a pathological sense, on the venous side, tend to be more fibrin rich. So they tend to have more fibrin in them, and that can be more of a component of the problem in dealing with venous things. So when we talk about somebody who has a deep vein thrombosis, or a DVT as we call it, so clots that are forming in their legs in low flow states in the venous side, those tend to have a lot of fibrin. So people with those low flow states and DVTs will probably be on some kind of actual anticoagulation. Same thing with somebody who is maybe immobilized, people in hospital or in the ICU, they'll be getting shots of anticoagulants that are actually preventing the formation of the fibrin in hospital to make sure that they don't develop those clots, because those clots in the veins can travel up into the lungs and cause a pulmonary embolism, and we don't want that. So that's kind of one of the reasons why we'll see the difference between people being on antiplatelets with some things and anticoagulation. So slow, not moving blood flow. So I'll just put that up here real quick. So we can have things where we have DVT, so DVT prophylaxis or prevention. We don't want that to happen. Again, that sort of ties into people who have had or are at risk for having a pulmonary embolism, kind of the same thing. But one of the major reasons why somebody might be anticoagulated, that's why it gets a special little star, is people with atrial fibrillation. So technically, you could argue that, well, atrial fibrillation is in the arterial side, because where we're worried about these clots forming in atrial fibrillation is in the left atrium. Because that left atrium is just kind of sitting there quivering, it's not doing anything useful. So it's not moving a lot of blood through that left atrium into the left ventricle. And that blood that's not moving is at risk of clotting. And that clotting that's going to happen, there's no damage there specifically. It's just blood that isn't moving. So that's more likely to form this kind of fibrin-rich clot just floating around in the blood. So if you imagine, say, something like your left atrium right here, right, there's your There's your pulmonary veins returning to the left atrium, if this is the left atrium here. And we just have, there's a valve that goes into the left ventricle. If this thing isn't doing anything useful, it's just sitting there quivering, this blood isn't moving, and all of a sudden you're at real risk for that blood just deciding to clot and causing this big fibrin mesh just sitting here because the blood isn't moving. And of course, that's also going to be filled with things like red blood cells and some platelets and all the rest of it. So if we create this clot because the blood isn't moving, well, that's what can go into the left ventricle and then out into the aorta and, you know, potentially up into the carotid arteries and into your brain and cause what's called an embolic stroke because that clot is embolized and gone up into those cerebral arteries and it blocks it off. So these tend to be fibrin rich. So these folks get anticoagulated as well. So when we get down to the fibrin stuff, well, what's the difference? The difference is, here's a platelet plug that'll eventually form some fibrin. When we talk about anticoagulation, we're talking about that fibrin specifically and how it's made. And that comes specifically from something called the clotting cascade. Now you might have been asking yourself, I wonder if he's going to talk about the clotting cascade because that's boring. And I am going to talk about the clotting cascade, but here's how I'm going to do it. There's lots of videos out there. I'm going to leave a couple of links and QR codes at the end so that you guys can dig into this a little bit more if you're really interested. But here's the clotting cascade as far as I'm concerned. Okay, we have a boo-boo. Okay, and maybe that boo-boo is just that this atria isn't doing anything, right? And we start to form a clot. There's a whole lot of clotting factors, just different different proteins, different things in the blood that kind of go through a whole system to produce clots. So when we get a boo-boo, let's just kind of nail it down how the clotting cascade works for what we really care about. So what happens is we get a boo-boo, and the first thing that happens is a whole bunch of crap occurs, and then it comes down to something we actually care about, which is going to be called factor 10. Okay, factor 10 gets converted into factor 10A. Okay, and when factor 10A, what factor 10A does is factor 10A actually ends up converting prothrombin to thrombin, and thrombin converts fibrinogen into fibrin. So it's a lot of words. It's a big process. We skipped a big bunch of it here because I actually don't really care about all that right now. Thrombin. Yeah, we'll just say that. We'll just say that this produces thrombin just to make it easier, which produces fibrin, and those fibrin clots that we've been talking about. Okay, my handwriting is getting way worse as we get lower because it's just the way it is. You can deal with it. So this boo-boo with the clotting cascade occurs. Factor 10 is one of the main things that happens, and then we end up converting, that is pretty bad, converting thrombin into fibrin, and that forms this mesh and this clot that's going on. So anticoagulation, the whole point of it is actually to prevent this from happening. So there's a couple of key things that can cause this, that can keep this from happening that you've probably heard about. Okay, number one that I'm going to talk about for anticoagulants is heparin. Okay, heparin is something that prevents a number of the things tied up in here from actually working and prevents the formation of the clot. This also actually includes something called, if you're really interested, low molecular weight heparins, which are things like Lovenox or enoxaparin, things that you get in a shot once in a while. We actually give some of this stuff if you're giving TNK as well, just to work on all aspects of this clotting cascade in somebody who's having an MI. But a heparin and low molecular weight heparins, they work to stop eventually the formation of fibrin. There's a couple other things that do this as well. There are a few newer things other than the heparins, because heparins and something called, as well, you're probably all familiar with warfarin. These are kind of the older anticoagulants that required a lot more. Warfarin is just the oral formulation, the things that people take at home, like Coumadin is one of the trade names, so they take warfarin or Coumadin at home, and then they would have to get their blood checked all the time to make sure that we're in the sweet spot of not being too anticoagulated, so you're at more risk of bleeding. We also have now, we have things like apixaban and called rivaroxaban, which I'm probably spelling incorrectly, roxaban right now, as well as something called dabigatran, or dabigatran, however you want to say it. So this one here, the heparins, kind of old school. People take warfarin, they have to check their what's called their INR, check their how well their blood is clotting. With these ones here, they don't have to check that. They have to take these, I think, twice a day. But these work kind of more directly right here on the 10 to 10A. So these, and then dabigatran actually works directly on thrombin. So these things all work in different areas of this complicated clotting cascade that eventually, what we're really concerned about is just producing fibrin. So the anticoagulants that people take from this side are just preventing all this mesh net from forming. Hope that kind of makes sense. Yeah, so if you see people who are on apixaban, rivaroxaban, dabigatran, Coumadin versus ASA, clopidogrel, and ticagrelor, hopefully you have a bit of an understanding about why they're on those different things. And if we take a look at this chart, what we actually have now is we can see, just broke it down for you here. On the left, we have the antiplatelets, and on the right, we have the anticoagulants, and just kind of broke it down. And you can see here on the left too, there's a little picture of an actual platelet. I think it really well represents my little green gooey guys on there, and versus the actual fibrin mesh that occurs and why we're actually getting anticoagulated. You'll also see that this breaks down what's called there's the generic names, or kind of the real names of the drug, versus the trade names, which are kind of just generally super confusing. But if you look at the trade names, just a fun fact, things like rivaroxaban and apixaban, you can see that XA is in both of those for the actual generic names, and that just gives you that hint that that actually affects that factor 10A, which is kind of interesting. So yeah, I don't know if that's on purpose or if they just got lucky for once with some of these ridiculous drug names, but there you go. So guys, there's a bit of a chat about anticoagulation and antiplatelets versus anticoagulation sort of in its truer form, and all the blah blah that I've talked about. So I hope that helped. Here's a couple of references for you guys to take a look at if you're interested. The top one is a, I don't know, 10 or 15 minute little video on coagulation that can be just sort of add probably a little bit more to what I said. The second one, the bottom QR code and link, links to a much larger chat on anticoagulation and some of the drugs that are used. It's really good and in-depth, and he's far better at whiteboarding than I am, so feel free to take a look at that if you want to get into it more. Drop me a line with any questions or any feedback on the video or any videos you've seen. You know, you get what you pay for, so this is the production quality you get, but I'm happy to talk about it or any other topic, as are any of the other island PPEDs, so feel free to reach out to anybody. Thanks very much for watching, and have a great day.